Okay, now you can go back to sleep. So, yeah, Doc, I'm tired. So before I start my comments, let me thank you once again for coming. It's just such a treat to come to Aspetar and share this marvelous place and these marvelous people. You have a wonderful team, and I thank you for that. So the title of the talk is, Are We Missing the Plot? I wasn't entirely sure what that meant, and I didn't bother asking, and so I just put together the talk. But as I reviewed the literature for this topic, it was really striking to me how consistent the literature's been over probably the last decade. So I don't think that from a literature standpoint, the plot is being missed. I think where we miss it sometimes is in our clinic. And as Rob pointed out, sometimes something like an exercise-induced condition, whether it's an asthmatic or a bronchospastic condition or an allergic condition, can simply be fatigue. And so you really need to have your antenna up. And I think that when we focus on orthopedics and musculoskeletal issues, we're really treating the whole athlete. And so I'm delighted that you're beginning to expand your scope because that's what we do in the athletic training room. And so we see these kids who come in who are depressed with an injury or they're not competing at the level they want to compete at, and we have to figure out why. And sometimes it's not an orthopedic condition. So again, no disclosures. So the goal of my talk today, fairly brief, understand differential diagnosis of respiratory and allergic symptoms. I have 3 cases to share with you, all from the crypts of my files, and be able to apply the appropriate testing, because that's very important, and then hopefully develop a management strategy for these conditions. So the first case, this is a University of Southern Maine. It's where I'm the team physician, and it's an 18-year-old sophomore. She had 3 years, came to us with 3 years of dyspnea. She felt her chest was tight when she would exercise. She didn't feel she could compete at the level she wanted to compete at. She complained of a cough. It would happen fairly quickly. She would almost always in a game, sometimes in an intense practice. And so within about 5 minutes it would start. It would subside when she would rest for a period of time, and then it would recur. She was taken to the emergency room multiple times when she was in high school by her athletic trainer, by her parents. At one point she was admitted to the hospital. She was treated aggressively for asthma, and she came to us on a multiple drug regimen. I think she had 2 inhalers and an oral medication. She had prednisone steroid bursts. It was quite remarkable. She had a little bit of allergy, seasonal things. Really high stress kid, very high demand family. And so we have to figure out what's going on. She came to us with a diagnosis of exercise-induced asthma. So I think the first thing we need to do is define our terms, because in the literature there's some confusion when you read about this. And there's exercise-induced asthma, there's exercise-induced bronchospasm, and there's airway hyperresponsiveness. And often these are used interchangeably, and they're not completely interchangeable. The thing they do have in common is that they have transient narrowing of the airways, and this is associated with exercise. So exercise-induced asthma and exercise-induced bronchospasm, one of the common factors there is that there's actually bronchospasm. But the exercise-induced bronchospasm is a response to exercise whether or not you have asthma. So I hope that that clears that up just a little bit. You do need to be careful about terminology. The numbers here are actually quite astonishing, and this is one of those things, if you don't regularly see this in your athletes, then you are missing it, because it's one of those things that sees us, but we don't necessarily see it. The numbers, at least in the United States, 12 to 15% of the population. Other industrialized nations, that number is pretty consistent across the world. Up to 90% of asthmatics, that echoes the slide that Rob had, and for people who have allergic rhinitis, up to 40% of them have exercise-induced bronchospasm. The prevalence data in Olympic and elite athletes is all over the map, and it ranges from very low, a couple, 3%, up to 60% in the U.S. Olympic team. And for instance, at the Beijing Olympics, almost a third, a quarter to a third of the mountain bikers had therapeutic use exemptions for asthma medications. So it's kind of all over the map, but it's very, very prevalent. And interestingly, it can be in up to 80% of swimmers, largely because of likely chlorine and chemical inhalation. And again, this has been consistent in the world literature over more than a decade. So what affects the prevalence? Some things you're, I'm sure, familiar with. Cold, dry air, certainly in my neck of the woods, where it can drop well below 0 Fahrenheit frequently in the winter, and it's very dry. We see a lot of this. Mechanical stresses, pollutants, very, very common. It's been a big issue in some of the Olympic Games, Beijing, for instance, even back as far as 1960, right, Mexico City, with a lot of pollution there, had a lot of respiratory issues. And atopic people, so family history has something to play. Chemical, as I mentioned, chlorine, bromine, other inhaled chemicals, and again, that family history. What I pictured for you here, just to kind of break things up, that's my nephew and my niece on the top of Mount Katahdin in the middle of the winter, and it was 20 below 0 when that picture was taken. They both have asthma, and neither one of them remembered to bring their inhaler. And so they had a bit of a struggle that day, but they summited. The room below is not someone trying to protect their environment. That actually was a practical joke that my son Samuel played on one of his roommates that went away for a weekend, and they went and they wrapped every single thing he owned, they wrapped in aluminum foil. So when he came back to college, that's what he found. He did not have asthma. The diagnosis, there are some things that are useful, some things are not useful. The history actually is probably the most useful thing that you and I are going to employ. The symptoms that they have, their response to bronchodilators. Interestingly, at least in my training room, one of the questions I'll ask my athletes is, have you used your roommate's inhaler when you get short of breath? And almost invariably the answer is yes. And I say, well, did that help? And they go, yeah, it did. And I go, perfect, diagnosis made. But the sport, the season, the timing, are they a swimmer, et cetera. In the US, and perhaps in the mall across the way here, ice hockey, and if they use propane tanks, they get a high level of nitrogen oxide in the environment, and that can trigger asthma. The exam that we do is almost never helpful because when you see them, they're largely asymptomatic, and testing then becomes critical and it's the most useful piece. I will do spirometry. It's inexpensive, it's easy to perform, and it's largely available. I train my athletic trainers how to do this, and I will do exercise challenges in the training room or on the field. And generally, a fall of 15% is pathognomonic. If there's a drop-off of 10%, there's in an elite athlete that might be the most significant. When you do this, you need to get their heart rate up to 80 to 85% of their heart rate maximum. You need to do that quickly and sustain it for about 8 minutes. And you can do this. I'll have kids run stairs. I'll have them run around the parking lot of my office, and then you measure their peak flows or their spirometry. You can do that every 5 minutes or so for about a half an hour. And again, that 10% number to 15% number is what you're looking for. The gold standard, and if you look at the literature, is the EVH. That is a very, very sensitive test that has very high specificity. Unfortunately, it's not widely available. It's very costly and requires a lab. However, if you are working with a lot of elite athletes and preparing a lot of therapeutic use exemptions, it's really something that is of great utility. The treatment here, there's some key points. Again, this hasn't changed a lot. So here I don't think we're missing the plot. There's a couple of non-pharmacologic things you can do using the warm-up. That from the American Thoracic Society has a strong recommendation when they've reviewed the literature on this. So appropriate use of warm-ups using that refractory period, very helpful. Short-acting bronchodilators are the cornerstone of prevention and treatment. The caveat with that is that something called tachyphylaxis can occur. So if they're using it frequently, they can get accustomed to the medication and it will no longer be as effective. Inhaled corticosteroids are also very effective. However, it takes about 3 to 4 weeks for them to kick in. So if you're going to have an athlete who is embarking on this, they need to have that expectation that it's going to take up to a month for those medications to actually help prevent their exercise-induced asthma. There are some oral medications. Leukotriene antagonists can have an immediate effect. They're not the cornerstone of treatment, but are a secondary treatment. And then mast cell stabilizers and anticholinergics also work, but not as well. And there have been a number of Cochrane reviews of this over the last 10 or 12 years. And again, a lot of consistency around the medications. That has not changed that much. And the American Thoracic Society echoes those recommendations. WADA considers EVH the gold standard for diagnosis. The allowed medications include the leukotriene receptor antagonists, such as cromolyn, docromil, and also ipratropium. Banned drugs, all beta-2 agonists are prohibited except the ones listed for you there. And this is very easy to pull up on that WADA app. If you don't have it on your iPhone, it downloads quickly. It's free, and it's very thorough. Glucocorticosteroids in competition are banned, and therapeutic use exemptions, we're all familiar with these. Interestingly, since the advent of TUEs for these banned substances, inhaled bronchoagonists have declined by almost 50%, which I find a very telling statistic. Although the preponderance of the evidence suggests that there's really not a lot of ergogenic effect from broncho-2 agonists. So our athlete, interestingly, very dramatic presentation, would begin quickly, end quickly, came on in only 5 minutes, and when you would distract her, it would improve. And she could actually speak. She can also hold her breath, which someone who has asthma will not be able to do. It only occurred during the daytime. And in this case, I think it had been misdiagnosed and average in this. So she had something called a vocal cord dysfunction, which is a paradoxical closure of the vocal cords. And it's often missed, and it's often very heavily treated as asthma, and it's very easily diagnosed. And there's a simple spirometry. It blunts the flow loop curve, so you can diagnose it on a simple breathing test. However, the gold standard is direct laryngoscopy, where you put a little tube, a rhinolaryngoscope down their nose. You have them exercise, and they'll have paradoxical closure. So usually when you breathe, you want your vocal cords to open, so you get plenty of oxygen. However, with these folks, they paradoxically close, and this is a good depiction of that. Open at the top, and you can see at the bottom with them breathing in how those vocal cords have closed. I think that's fairly evident. There's various types of that, but at the end of the day, it's paradoxical closure. This is actually easily treated with speech therapy, so we have a speech therapist that we use for all of our kids who have this, and it's really the cornerstone of treatment. So it's something that they can learn through exercise and speech therapy to overcome completely, and it works brilliantly. So moving on to allergy, a couple of cases here. It's a 14-year-old kid. She's a freshman in high school, and she was kind of out of shape, hadn't worked out in the summer. New fall soccer season, it was a hot day, and she was running with the team and felt really poorly, lightheaded, her skin felt like it was crawling. She thought it was kind of hard to breathe, but she was out of shape. And she was noted to be kind of wheezy and tearing and upset. red mottled skin by the coach, and she was sent home. And her mom said, well, she had a rash that went away after a couple of hours. And then she got in a hot tub because she was kind of achy after practice, and the rash came right back, and she felt kind of poorly again. She had a family history of allergies, again, a lot of stress in the family. Case number 2, now this is a collegiate runner, very well-trained kid, very competitive in the league, and she presented with very sudden fatigue, feeling flushed. She was pruritic, she was itching all over, and again felt poorly, hard to breathe. She kept running, developed abdominal pain, and then blacked out. So that's a very concerning picture. She was noted at the time, because she was running with her team, that she had small rash all over her body. Those symptoms all lasted for about 2 hours, and she got a headache afterwards. And her history was that she was atopic and had eczema and various allergies. So here we have some similarities, but some stark differences, and so we have a couple of different diagnoses here. And for case 1, it's exercise-induced urticaria, all right? Fairly benign and can be self-limited. But case number 2, much more worrisome, and that's exercise-induced anaphylaxis. And the interesting thing about these two entities is that they share a pathophysiology it's really quite distinct from exercise-induced asthma. So it's a heightened cholinergic response. Mast cells degranulate, histamine levels are elevated, and then you get transudation of fluid, which causes the hives, causes the rash, causes some of the difficulty breathing. Now, some people think this may be a continuum of disease, but there are some distinct manifestations, and I just want to point these out to you. That with cholinergic or exercise-induced urticaria, which can also be related to temperature, that kid got in the hot tub, very small wheals, the upper body, the torso is most common, and the precipitant really here is an increase in the core temperature. It happens quickly, it lasts for a couple of hours, and then generally goes away. The treatment for that is antihistamines, and first-generation antihistamines, if they tolerate it, you can use, and sometimes have to use, very high doses of this. The problem there is it can make them sleepy, and so sometimes the second-generation antihistamine is a better choice, and you can actually add H2 blockers, and I've had to do this in a number of athletes who had this, where I've had to go to 2 agents to control this, because it is uncomfortable for them when they're exercising. If they get systemic symptoms, as our second runner did, then it becomes actually a medical urgency or emergency. And I've only had probably 3 or maybe 4, it was a little questionable, who had this in my practice. And I had them always run with somebody else and run with an EpiPen, because the treatment there immediate is epinephrine, and then emergency support when they get to the emergency room. With all of these, of course, modification of activity and avoiding triggers. In an athlete, they're simply not going to modify that much, and they're not going to avoid their triggers. The antihistamine is really the cornerstone treatment to begin with. There are a number of things that you can do as a third-line agent, such as doxepin. If you have food-related allergies, so for instance, peanuts, shellfish, celery, citrus, particularly strawberries, for whatever reason, can precipitate these attacks. Interestingly, that can present 24 hours after ingestion of those things. So if someone says, yeah, I went and had some Chinese food yesterday, and then they have it today, say, well, let's try it again, but don't eat Chinese food, which often has celery and peanuts and other things in it. So you can modify their diet a little bit. Anticholinergics are not useful, interestingly, even though it's a cholinergic phenomenon. Things like beta blockers, again, not useful. So in summary, for the allergic phenomenons, EIA, it's really, really common. Be aware of it. It's there. Your athletes have it. Note that there are alternative diagnoses. For instance, in our basketball athlete, vocal cord dysfunction, testing beats your H&P for diagnosis. Short-acting bronchodilators are your mainstay of therapy, while there are other things that can support that, and be aware of the WADA regulations on that. With the allergic phenomenon, urticaria versus anaphylaxis is the cut point. That's where you need to be in your diagnosis. And there are differences in the presentation, particularly the rash. Antihistamines and prevention really are key there. Did I make it? All set. Thank you for your attention.